Hello everyone, welcome. I'm Simon Bourne. I'm the Programme Director for the Midlands Decision Support Network and Principal Consultant at the Strategy Unit. And just wanted to welcome you to Insight 22. This is our annual Festival of Learning and Sharing events for the NHS, for local government and for other partners across health and care. And it's hosted by the Midlands Decision Support Network in association with the Strategy Unit. This year's festival runs over 2 weeks. It runs between Monday the 21st of November, so today, and Friday the 2nd of December. And this year the theme is the science and craft of decision making. So we're bringing together a really nice range of speakers from health and care providers, from system leaders, we've got national leads, we've got perspective. Together, we're going to be considering how we make decisions in health and care. We're going to be looking at some of the processes, we're going to be looking at some of the constraints, some of the politics, the ethics around decision making. We're going to be thinking about what's happened to date in health and care, but we're also going to be spending some time thinking about the future as well, and what it might be. The whole thing is online. And everyone with an interest in health and care or decision making is very welcome to attend. We've got about 4,000 people signed up to the festival as a whole, and that's rising still. And so we're expecting at least a few hundred at each of these events. And you can come to as many or as few as you like. So if you haven't already, please do take a look at the wider programme and sign up for a few more. And I'm sure one of my colleagues can post in the chat box a link to where you sign up to the wider festival. So I'm going to say a little bit about today's session. First of all, so today's session is about ICSs working together to become intelligence-led organisations. But just before I do, a few little housekeeping things. Obviously, there's quite a lot of us in the room, a few hundred and rising. So please keep yourself muted during the session. It'd be great if you could introduce yourselves in the chat box, just so we get a sense of who's in the room with us today. But also, if there's any technical issues, I'd love it if you'd put a few comments or start asking questions over the course of the session. As I'll say in a minute, towards the end of the session today, we're going to have taking some questions from the audience, and so it'd be great if we've got a bit of a store of those from over the course of the session that Nigel can draw on when it comes to that. If you'd like, you can tweet about the sessions using Insight 2022, or tweet us at Midlands DSN or at Strategy Unit, and all of our sessions are recorded and put on our website as well. So today's session, we're going to be covering ICSs working together to become intelligence-led organisations. So what we'll be talking about is, first of all, we're going to talk a little bit about a bit of an overview of the Decision Support Network model. So that's a learning network model that began in the Midlands just over 2 years ago. It's now been taken up in the South West region, and I think it's increasingly leading the way as a means of advancing analytically led decision making and supporting collaboration between systems. We're then joined by Nigel Edwards, Chief Executive of the Nuffield Trust, and Nigel's going to be sharing a set of initial reflections, so some lessons from history that he's drawn together for those who are looking to become a learning system. He'll also be sharing some of the key opportunities and challenges that this presents in his view. Nigel will then be moving on to host a panel discussion with us, and we're joined by a really fantastic panel. And I'm on it as well. We've got Sue Ibbotson, Regional Director of Public Health for the Midlands region. We've got Pete Jackson, who's Improvement Director for the West Midlands branch of the Association of Directors of Adult Social Services. And we've got Ali Loftus-Hills as well, who's lead for the South West Decision Support Network and Head of Improvement Delivery for NHS England. And I'm sure Nigel will contribute some reflections into that discussion as well. And we'll see where that discussion takes us. We might use the whole time, we might finish a bit early, we'll just sort of see where that goes really. But to start with, as I said, I'll do a brief summary of the Decision Support Network model and its underlying principles. So skip through. And that's just a bigger, longer list of what's coming up in the festival. So just to start with, so the Midlands Decision Support Network essentially kicked off just over 2 years ago, as I said. And it essentially represents a learning network which connects all of the intelligence functions across the ICSs in the Midlands. So each of the 11 ICSs has got an intelligence function, as does NHS England for the Midlands region. And the idea is that they're part of a network together, so a wider network that goes across the region, and that represents an opportunity for those various intelligence functions to share their outputs with one another, to collaborate with one another on shared projects, but also to learn from one another and to share skills as well. And we'll go on to that a bit more when we come to the discussion. And then the idea is that each of those intelligence functions is connected by a development centre, and that's something that my organisation, the strategy unit, runs. So ICBs and NHS England for the region of pooled resources, and then the strategy unit working with our local knowledge and intelligence service for the Office of Healthcare Improvement Disparities, of Inequality and Disparities, working together to host this development centre. And what this development centre does can be broadly broken down into 3 main pools of activity. So the first is essentially quite a large programme of training and development, which is focused around building the capabilities to support better strategic decision making. So that's about, we do about 1,000 training and development places per year on courses some of which is focused on technical development for analysts. So building some of the technical capabilities needed for population health analytics, things like system dynamics, things like various operational research methods. So essentially the more what you might associate with high quality analytics. But also a significant component is around building the analyst decision maker relationship, building leadership development skills in analysts, essentially helping analysts to move into more board facing roles. There's also a significant component around decision makers. So how do they use analytics more effectively? How do they draw on analytics in their decision making processes? The second main bit of activity is around a regional analytical programme. So each year in our network, we do a call for ideas across all of our public health and analytical networks, and essentially come up with a long list of analytical projects. And the point for those projects is that they're on issues that matter to all of our systems. They may be on questions that are long-standing and maybe have received insufficient attention in the past. We go through a prioritisation exercise and undertake a number of those each year on behalf of all 11 systems at once. Third main bit is essentially around knowledge exchange. So, I think as part of the network, we're recognising that sort of collaboration and sharing between systems that we want to see doesn't just happen by default. It needs an organisation force and it needs some energy behind it. So we essentially run a number of communities of practice, the various roles that support decision making, so analysts, leads for evaluation, leads for evidence review and knowledge mobilisation, and we support them to undertake collaborative projects as well. The other thing I wanted to mention is just that the various things that we do in terms of advancing decision making practice. So we act as a sort of development centre for the region, really working with individual systems to help them think about how they might do decision making differently. So how might they involve their populations more effectively and meaningfully in strategic decision making, but also things like how do we apply analytical methods at scale. So people on the call who are aware of STAR as a methodology, so socio-technical allocation of resources, that's something that we're rolling out at a sort of unprecedented scale across the network to look at, well, first of all, to look at resource reallocation in COPD pathways. And we use the network as a means of building partnerships and support as well. Last few things I wanted to say, and because I don't really want to cut across our discussion in a minute, but it's just to highlight a few principles, really. So first of all, was something around the fact that this is a locally owned arrangement. So it's owned and it's governed by the health themselves. So rather than it being something that's sort of top down or been required by national policy. And I think that's really helped to give it a sense of shared endeavour, maybe more of a sense that collaboration could lead to improvement. And actually it has led to, it has as a model started to spread a bit more organically. So as I said earlier on, it's spread to the southwest region now. I think it's had an influence in some of the national policy that's coming out around intelligence functions. The other thing that I wanted to say was really that the network's helping move our systems towards a culture of collaboration by default. So we're trying to support the move towards each system having its own established intelligence function, but that, essentially each of those intelligence functions is going to have capacity for working on strategic analytical questions, and we can essentially help them to collaborate by default. So reducing duplication, improving the quality, essentially sharing ideas and expertise and undertaking shared work where it makes sense to do so. But also potentially doing that at regional level. So with other network arrangements coming online, like the Southwest one, it gives us far more chance to collaborate across regions. So, looking at potentially shared analytical projects or shared training and development opportunities. And we're already starting to see that. So the Southwest and the Midlands region are working on some shared analytical projects together. And also next year, on behalf of all of the regions, we're going to be hosting the first NHS Data Science and Analytics Conference. So things like that. Another key aspect I suppose I wanted to highlight was around that we're focusing on some of the supply and the demand issues for analytically informed decision making. So it's not enough just to have high quality analytics. As I was saying, essentially we're trying to focus on building some of the skills and the capabilities around decision makers as well, in using analytics in informing their decisions. Another key aspect, I suppose, that underpins it is really recognising that there's perhaps a need to protect space for analytics as opposed to BI. And I'm not trying to sort of set up a hierarchy between the two, but essentially recognising that there is a difference. And with analytics being sort of drawing on a range of various technical disciplines to address specific questions, whereas perhaps business intelligence is more on the routine reporting needed to enable day-to-day decision making. And what we found is prior to this, those two have often become conflated, despite a very different set of skills being needed, and that often the BI and the sort of data management challenges have tended to crowd out the space for in-depth analytical work. So that's what we're trying to do through the network, is create a bit of space for that analytics to happen, both at regional level through that program that I mentioned, but also at individual system level as well. And finally, and this is something we can build on later in our discussion, but just trying to use the scale of this network as an opportunity, really. So it represents about a quarter of the health and care systems in England, and now that the Southwest has a similar arrangement, that's 18 out of the 42. So we've used it pretty successfully in the Midlands to build partnerships with public health, with social care, with various academic institutions, but also I think there's a pretty significant untapped potential around how to use something like this to start trying out new innovations at scale, evaluate them effectively, and potentially roll them out. So that's something that we can maybe talk about later as well. But at that point, I'm going to stop. So that gives you just a bit of background context, and I'm going to hand over to Nigel, who's going to give you his initial reflections. So over to you, Nigel, when you're ready. I'm going to stop sharing.
Thanks, Simon. I will also now attempt to share my screen. I was asked to sort of reflect on some of the things that we've learned over the years around the creation of decision support. I'm just wondering if I've actually managed to do this successfully. Let's see. Right. Can I just check that?
Yes.
You're now getting a slideshow. You've got but I've shared the wrong one, so that's not very good. Very interesting presentation on capital investment in Eastern Europe, but probably not what is required now. Here we are. Good. Now you should want something that says some key lessons. Is that okay? Have I got that?
Yes, some key lessons.
Good. So some key lessons from previous forays into various types of strategic decision making and the analysis to support it, and some considerations that we might want to think about as we design the sorts of learning systems that ICSs will want to put in place. I mean, I think the first thing to say, just listening to Simon's presentation there, this is a fantastic initiative. It's not something that I see in a number of the other countries that I work in. It is relatively new for the NHS, and there will be some challenges to keep it going and to keep the energy up and to make sure that it gets really properly embedded. And I think in doing that, it's worth just reflecting on some of the things that we've learned about what's good and what's been not so good about the way that the NHS has attempted to address some of the big decisions that it faces, both at a national and at a local level. And the first cluster of things where I think particularly analysts and some of the disciplines that they bring can help is in actually getting the diagnosis of the problem you're trying to solve right. So that includes both the processes of curiosity to understand what's going on and to look for the opportunities for change and to ensure that those are fully understood, and then really specifying the question that you're trying to answer in doing that. The NHS is very full of sort of assumptions and hunches about the way that the system dynamics work, and quite a few of those, when you start kicking the tires on them, prove to be only partially true. One of my favourite examples of this is the 85% occupancy target as a sort of modelling assumption when you're looking at bed numbers. It's true in certain circumstances, in certain types of specialties, for certain types of models of care, depending on what your objective is. It could be too low, it could be too high, but unless you understand what goes into the basic assumptions there, the thoughtless application of numbers like that into planning assumptions can very seriously lead us astray, and in that particular case has real world consequences. If the hospital ends up operating at 120% occupancy because you've chosen the wrong average, people will die. We know that. If you get it too wrong in the other direction, we'll build things we don't need, which will then get filled up with patients. So all of this matters. So getting a much better understanding of the root causes of what's going on, and I think again that's something we're not being good at here. We tend to do static models. We don't understand enough about the dynamics of the system and how the various parts of it interrelate. So a very important part of any learning system and the analysis support of it is to bring some of these disciplines to bear and create dynamic models that understand the problem and get to the heart of the issues in a rigorous and evidence-based way. Having diagnosed a problem, we've still got opportunities to get it wrong through poor design. So one of the problems here is actually getting a shared understanding and definition of what we mean. The last time one of the researchers I know who looks at these things had a look at the literature, she found over 170 different definitions of the term integration. It's probably one of the best examples of an extremely slippery concept, but actually, if we find when you start digging into this, some of our assumptions about what we're trying to do are not necessarily fully shared or properly understood. So bringing a bit of rigor to that, obviously very important at the point you're then going to apply some any analytical tools to the issues to really understand what you're doing. The second thing we've learned is that when we go and look at service models and we want to change, and we go and look at other people's, is really understanding what is the active ingredient that actually makes the model work. Is it the way the service is designed? Is it how it fits into the context in which it's located? Sometimes, and this is very difficult to replicate, and one of the least interesting research findings is it may be the type of people who are managing it and how they go about doing doing their job. That's not always that easy to replicate, it turns out. But we've got lots of examples of models that look quite good in their context, but when transported to other places don't really behave in the way that we expect. A good example of this is GP streaming in the ED. GP streaming is probably quite a good intervention if you've got poor primary care in an area, or an area which has a population that is used to the idea that hospitals are where you go in an emergency. Luton would be a very good example of that, and that's where the model comes from. It probably doesn't work 40 miles away in Oxford, where primary care is very good and the population have a very different habit of how they use the primary care system. So understanding the context and the active ingredient, really important. And then the other bit of the design, which again I think many of you on this in this seminar will have good experience of, is getting the logic models right. We see quite a lot of logic models where, frankly, the strength of evidence that is connecting the inputs and the service design to the outcomes and outputs are pretty ropey in terms of actually whether or not there is really a plausible causal connection between what your plan is to do and the outcomes that you're trying to achieve. We seem to have a particular issue when it comes to interventions which are designed to reduce admission, and this is again, I think, where a system dynamics perspective brings something to the table. We know that, and in fact, analysis by the strategy unit has shown that the threshold for admission has changed over the last 10 years or so. So it's now harder to get into hospital. If you create a model like the full service that Amanda Pritchard announced, designed to prevent admission, you may well prevent admission of the individuals, but you may not prevent admissions globally, because there are other people who can be admitted into the spaces created by the service that you've designed. So this is fine if your objective is to stop people having falls which cause them to have sometimes often terminal decline, but certainly some life-altering injuries and further pathology. That's great. But if your objective is to reduce admission to hospital, you may fail. So being very clear about what the objective is and what the logic is that drives it seems to be a really important lesson from all of this. Then we get to the implementation phase. One of the perhaps less to say on the analysis side here. Many of the problems that we experience here are actually about a poor change theory and inadequately thought through methodology of how we make change. And our old friend, the planning fallacy or optimism bias, which is the almost inevitable tendency to underestimate how long it is going to take to do things. So providing a bit of discipline on that, and reminding people of all those timetables and to-do lists that you make, and how often one actually achieves what one has written down, is something worth thinking about. The other thing I think that we've really neglected is the extent to which many of our models, the technical side may be fine, but the organizational development components that follow on from the decisions that we make are often really rather neglected and under-invested in, and this has been a particular issue in the NHS in the deployment of digital technology. Quite a lot of what we do is a people business, not just a numbers or technical business, and we can certainly see in, for example, the development of primary care networks. I think we've really failed to understand just how tricky it can be to incorporate even a relatively small change in, say, the staffing and organisation of a group of practices. So something to a big lesson there that needs to be factored into the decisions that we're trying to support. Having done all of this, and I think again a really important contribution from the analytic community is in getting better at evaluation, and this means designing the evaluation and when necessary collecting the baseline data before you implement any change, rather than having to perhaps reconstruct it afterwards. Being clear about the outcome measures, with the caveat I mentioned earlier about, for example, the reducing admission target, but being really clear that your outcome measures do actually relate to your logic model. And then I think the thing which we find often goes most wrong is stopping the evaluation before you've actually really got sufficient power or time to allow the intervention to have bedded in, for there to be sufficient numbers of people who been through the new model or the new service. And we often give up on the evaluation, but actually before the models have really even bedded in. So a really interesting and quite worrying tendency, for example, in the evaluation of various types of multidisciplinary and integrated care models, to find the intervention arms actually doing worse than the control arms. And I think some of this is to do with the fact that we've actually given up too early on some of these things. And then again, I think something else that can be brought to the table here is making sure that we've got appropriate methods, and in particular a good mix of both quant and qual methods to understand what's been going on. And sometimes the qual component of that is as important as the quant. So having done all of that, ensuring that we've got a method for continuous learning and feeding back the data that's generated by the system back into practice and having it used. And we're a bit obsessed with dashboards, but they do have their place. But being relatively parsimonious and understanding which one of those are important for learning, and maybe, as Simon was sort of suggesting, and we'll perhaps come back to this, having this slightly separate from the routine reporting, but actually pausing deliberately to think about what you've learned rather than just having it as a sort of routine. I'm not sure on the answer to that. Perhaps we can discuss that. And then I think the other lesson is that we've generally underinvested in analytic capability. I mean, if you visit integrated healthcare systems, particularly in the US, one is really struck by the extent to which they've got really very sophisticated ability to bring together both quant and qual information to create rich pictures of what's happening. We're going to have to do more work to try and ensure that we know who's got expertise and how we can avoid duplication, as Simon was saying. There's more to do to develop the careers and bring on analysts and ensure that people are properly mentored and supported. And then I think also there are some skills we need which we can't replicate everywhere. So understanding where those are and having networks to be able to access them are going to be really, really important to make the best use of the resources we've got in the system. In all of that, there are some challenges and some opportunities. As Simon was saying, I think sort of the interesting question about how far this is just an add-on to BI as opposed to actually a separate but related function that brings in perhaps different types of skills, particularly sort of more advanced analytic skills, which also helped co-create the investigation of problems and decisions rather than simply respond, I think is an important opportunity. And the challenge is not to get the day job, the day analytic job of producing large amounts of information, which I see the current Secretary of State is perhaps suggesting we might row back on a bit, but not let that swamp these other rather more important questions about how decisions are made. Opportunities to learn from others and to also ensure that the one thing I think I've really benefited from where I work is having analysts to actually understand the system they're analysing, so that the number that we're not just looking at numbers. Actually, the numbers relate to things that we understand. So ensuring that people in the network really understand the business that they're in and how these the numbers you see on the screen or that are spat out from your code actually relate to real life events that affect staff and patients. I think is a really important element of building the capability to support decisions. Having run networks in the past, I've got a typo, that's annoying. One of the things that actually is quite tricky is keeping the energy going and making sure that people keep connected. So it's great to be reducing duplication, but actually keeping people going and engaged when they've all got busy day jobs is a problem. And some of that we can do through sort of cross-system mentoring and career development, which has its own challenges, of course, because it may mean that people reach a point where they have to move to get development, and we have to sort of welcome that and allow that to happen. And then finally, I think ensuring that we've got the ability to manage both the day-to-day and the strategic pressures is really important. So there's probably more that I could have said and haven't. But now we have an opportunity to hear from our panelists and get their perspective on that. And I'm particularly interested in hearing from each of them about how from their perspective, decision support networks can add value to the NHS, and whether they've got any other sort of lessons and ideas that they think I've missed. And I think I'll go slightly alphabetically and go to Ali first, if I may, and put that question to you and get your perspective on it, Ali. So over to you, and then I shall come to Pete.
Thank you, Nigel. Can you hear me okay?
Fine.
That's great. So I'm Ali Loftus-Hills. I know Simon introduced me, but just to mention, I'm Head of Improvement Delivery in NHS England in the Southwest. And I have had the pleasure of working with Simon and colleagues over the last year, looking to establish our own Southwest Decision Support Network. And I guess for me, the way we went about doing that was really sort of key, because we started with a listening exercise to talk to as many stakeholders as we could across the region, within public health, within academia, obviously within the NHS, but looking at both those who were sort of trying to strengthen their intelligence functions in line with the ICS policy guidance, but also those who were sort of in positions of needing to utilise you know, sort of analytics and evidence more. And that listening exercise really identified where there was huge opportunity. A lot of the things that you've just talked about, Nigel, really resonating through that. Really trying to get the building blocks in place, I think, is the first thing, both in terms of within the NHS, but then across the different sectors in how we can join up better. And I think there's a real journey that needs to happen there in terms of maturing the intelligence functions that are in place, but also in that connection between those creating both the BI and analytics and those utilising it. And I think, you know, that's something that I know certainly Simon and colleagues and others have been working on and developing for some time. So I think the other thing that became really apparent was the potential to really create that space, which is the way, Simon, I think you put it, but it's about trying to actually make sure we've got the capacity and capability in the right places as well. You know, giving that space for you know, to be curious and to you know, to get those questions answered. I think that was the second sort of key thing that came across. My own area and my own sort of real curiosity is in knowledge utilization. It's something I've been working on for some time, and I think that's the other bit that I think really came across is that from our stakeholders is, you know, how do we recognize the complexity of systems, the complexity of the answers you get to these, you know, the sorts of questions that are being posed, and bring people along with you so that actually when you create this knowledge, both from and from around a perspective, that it will be utilized, you know, in practice. So I suppose it was those three. One other thing that sort of came out in terms of a challenge, Nigel, is how we create rounded intelligence functions, I suppose, which is what you were talking about around having quantitative analysis alongside the qualitative, you know, so looking at evaluation, but also making sure that we're including health economics. We're looking at the workforce analytics, which is obviously in the, I mean, across the NHS, across all areas, is a massive challenge, and a particular challenge in the Southwest region, in particular specialties and areas. So yeah, that's my starter for 10 in terms of what we need to be doing. And I think the Decision Support Network, we're at the beginning. You know, we've just kicked this off. We're building on some fantastic stuff that's already in place. But you know, I really think that opportunity for collaboration that a Decision Support Network creates is the key thing that we're going to be utilising and focusing on in terms of bringing people together to solve some of those tricky issues. I think you're on mute.
Someone had to do that first. That's
Yeah.
me. So should have known by now. Been doing this for long enough. So thank you for that. Yeah. Let me come to Pete, and let me encourage people to put any questions or thoughts into the chat, which I see some of you already started doing. Pete.
Thanks, Nigel. And just sort of building on some of the points that Alison has picked up there. We've been working as West Midlands ADIS, Directors of Adult Social Services, with the Decision Support Unit, I think since pre-COVID actually, so that seems quite a long time ago now. But those discussions were very much around, from a social care perspective, about how we get better at sharing our challenges, but also our data and knowledge, really, around how that influences local systems. And we think we've had some big successes, really, in terms of developing that and understanding really what the Decision Support Unit can do with us. We'll use the term sort of collaborative advantage, about win-wins really, and we recognise that within the social care sector, the capacity around analytics, around modelling, around some of the more specialist things just aren't available. So it's a world that we've become more familiar with and been able to have conversations with Simon and the team about how we can look at this through the lens of social care, which obviously often gets either forgotten or skipped over really when we talk about local care systems or integrated care systems, as you've said, Nigel. So we've been developing our own sort of knowledge hub, our own bringing together of our own data, but using and working with Simon and the team around, for example, work around domiciliary care, which for social care is an enormous issue, and it is for health as well, in terms of the scale, the volume, but the real lack of understanding around the dynamics around domiciliary care. So we've been building a model with Simon and the team, which we think is a really good attempt and has opened our eyes really to the importance of system dynamics, and using our own data with expert support to start to plan and to project how some of those pressures may be mitigated. We've also been working very closely around the whole concept of, I suppose, scenario planning and future-proofing some of the work. Social care generally not very good at these things, very often considers being reactive. And I'd give a plug actually for a book that's I'll try and put it in the chat, that's just been published this week by a colleague from the Midlands, Richard Humphries. Some of you will know about ending the social care crisis. There's a whole chapter on learning the lessons from history and really understanding how social care has got into the situation that it is now. But I think that understanding social care, understanding the scale really of the number of people involved, the workforce involved, the pressures, actually is something that we're generally bad at communicating and for local systems to understand. So we've been doing quite a lot of work around how we start to think about social care being part of that system. What are the assets and knowledge that we hold that we need to be better at sharing? That relates particularly to, I think, population health management and future planning. And then the third area, which I think importantly both of you have touched on, is around capability and capacity. And within local government generally, we recognise that there's a deficit that really that's been created around general policy development, around analysis and around performance planning, which, you know, is a consequence really of investments over the last decade or so. And that makes it even more important, we think, to encourage this collaboration and collaborative advantage by recognising that we can't do these things ourselves, or it's very difficult to do these things ourselves. But by working with the Decision Support Unit, we've obviously been able to build relationships, start to understand the language, start to break down what some of the barriers are, both in terms of governance, procurement, contracts, all these things that actually, when you get down to it and you get down amongst the weeds, are really important to be able to deal with quickly if we're going to keep momentum going. And I'd sort of finish by saying that we talk a lot about sort of flipping social care, about trying to look through social care from the point of view of the service users, the people using services, from the point of view of communities and the local local places, I suppose. And I think this is where I was really, you know, been encouraged by the work of Simon and the team, really, about thinking about building that local reverse telescope, looking things from the bottom up rather than the top down. And I think that's where I think there's some real advantage in having this a regional approach to that, where we can all contribute, but also actually build the relationships which you need really to make this sort of approach work. So really, really grateful for being involved, Nigel, and thanks for the opportunity to contribute.
Thanks. Where would you see the most significant opportunity, at least in the short term, to get traction for some of that? So you've been laying the foundations and getting an understanding of what's happening, but where do you think you've got the most significant opportunity to intervene or to change the direction of thinking, for example?
Well, I think using the example of the domiciliary care actually is a really good example, because I think it doesn't feel appreciated really about the scale and volume of people involved and being looked after in their own homes. We often obviously talk about hospital admissions and getting people out of hospital, but actually there's far more people actually being cared for at home than there are in hospital. And I think looking at the model and looking at the workforce challenges that faces with us has been something which actually does become tangible, and it does start, people's eyebrows start to raise when you talk about how many locations, how many people, how many services are being delivered at, you know, very local level, literally in people's houses, but in every community. And actually understanding the dynamics of that, I think, is a really good place to start, and where I think we've made some really good progress.
That's a really interesting example of perhaps helping people reframe how they think about a problem. Have you encountered sort of very different sort of approaches to the decisions and the data and the analytic questions between the different sectors that you're working with? Is that something that people need to keep an eye out for?
We often, you know, we talk about maturity, don't we, or levels of maturity. We particularly thinking about the ICSs really, and people obviously say there's quite, you know, there's some more ahead than others actually. And then when you do start to break it down, everybody is trying to approach this from their own local situation, and that gives an advantage in some ways, because that's talking about your local community, but it's a disadvantage in terms of us being able to scale up and to learn lessons and share what's working in some places opposed to others. So I think that again is that up bottom down, top down bottom up sort of approach, and thinking about how do we get the best of both really, which I think is why the level of the decision support unit operation as a region actually gives both of those attributes.
Thank you. Now, Sue, I think I had a few technical issues earlier, but hopefully you can hear me. Do you want to give us your perspective on that and tell us a bit about what you're doing and particularly the relationship with public health and where that's where you see that going? No, we haven't got audio from you. You're not muted. No. Oh dear. Can you hear me? Wave if you can. Right, we're not. Yes, great. I wonder whether we could get you. You might need, if you've got a phone, you can phone into the Zoom meeting. So while you're doing that, I might just go back to Ali and ask to just reflect on perhaps some. Tell us a bit of the history of your approach and it's how you see it. Are there key differences between this and the West Midlands that are worth exploring?
Yeah, sure. So just talk about what was the really sort of the trigger to do this piece of work. I think there's a few things. I think there's a recognition that that we weren't doing this as well as we could, I suppose, like you're saying, more diagnosis needed, more curiosity. I think at the beginning we were talking, Mark Cook and other colleagues in the Southwest, who's our Director of Strategy and Transformation, around you know, there's a really significant opportunity to come together and address some of the problems that we're trying to solve, and to to design something that might work more effectively. And I suppose alongside that, the integrated care policy was published, which was around how can we strengthen the cross-system intelligence functions? How can we do this better? So as I said, we conducted a series of interviews. We spoke to stakeholders across all of the 7 systems. There is a huge appetite out there, and I suppose the thing that's really clear is that you've got analysts sitting in providers, in systems, in social care, public health analysts, and they're all working on something on cross-cutting issues, but they're not working necessarily together on them. You might get the key people together who are trying to solve that, but you won't necessarily get the analysts together, I think. So I think that ability, that where the appetite was people who don't often, or in their day job, are not able to necessarily either know who's doing this work in other areas. So that mechanism to bring people together, really seen as valuable as a starting point. And then to explore the other thing that I think there's been huge enthusiasm around is, what can we do at scale? What can we do that doesn't, that avoids duplication? A lot of the things around addressing health inequalities, sustainability has come up a lot, elective recovery and how we can understand the challenges around elective recovery from a health inequalities point of view, but also the models of care that you can use. So really taking that evidence base, but they're always trying to solve the same, similar problems. So I think for me, that's really our starting point in the Southwest, is setting up those connections, as you say, Nigel, keeping the enthusiasm in there when people are trying to run their day job alongside it, and trying to identify. And the 2 things that I'd sort of want to dual run with this, or from listening to people, is what things can we crack on with now? So we're putting some leadership for analyst training in place. We're putting some decision quality. I know there's a question in the chat I saw about how can we engage with managers on some of this. And I think the way that I know certainly the Midlands has, and they're supporting us in providing this training, is decision quality, which is bringing people, executives and senior leaders and other managers in, and teaching them, or coaching them through how do you use intelligence and insights effectively in your decision making. So there's that side, but also the leadership side, which is around how do you help formulate problems better, challenge back, story tell, so that the insights that you're creating resonate with those who are making decisions. So that's the first bit, and sort of there's some immediate things that we can do. There's some immediate at scale pieces of work that we're trying to identify. I think the slower burn is how we create and strengthen ICS cross-system intelligence functions. It's going to take time. I think there's huge challenges that you've laid out. Things are not necessarily in the right place. People are not necessarily doing the right things. So I think that's the bit. And to that end, we're bringing an intelligence function development group together of initially the 7 leads, but it will certainly broaden out as time goes on. But really that's sort of looking at maturity and looking at the building blocks and what can be put in place over time, and how we can support. NHS England is a convener of this. The network is owned by the systems. We're very much seeing ourselves as conveners, and over time the model that we've got in place may change. But we do have really good, I think the other thing just to mention is really good executive buy-in to this as well. So we've got an ICF chief exec who is keen to chair it, actually is going to chair it, and a fantastic advisory group with public health, social care, the AHSNs, NICE, all coming together to help advise on how we develop this going forward.
Thank you. Now, I don't know whether Sue has managed to join us. If you have, then
fingers crossed.
Fingers crossed.
Yeah.
No, I'm going to. That's a shame. Perhaps I can ask the organisers to see if they can try and make contact with her. I thought I would just pick up a question, which is, how do you know if you've actually got curiosity? Which is a very good, if somewhat abstract question. But just give you my perspective on it from my organisation. I'm always on the lookout for issues which look really important but don't appear to have had enough study. and where there's a researchable question. And one of the reasons, one of the ways that we know if we're getting this curiosity right is at some point somebody will come along and say, we're really interested in X, and we're able to say, funny enough, we've just done a whole lot of work looking at that and understanding it, and we find therefore that we're several months ahead, if we're lucky, of people asking questions. So one very tangible way is to sort of be constantly scanning what's happening and ask yourself the question: does this look important? Are people paying sufficient attention to it, given how important it needs to be? Is there a investigatable question that we could look at that would help shed some light on it? And is it possible to do a little bit of investigative probing so that you can test further whether or not it's something worth looking at? So I mean, I run the think tank, for which that's a fairly mainstream activity, but we've had quite a bit of success with that. Simon, did you want to just come in on that?
Yeah, just to build on that point, really. So I think one way to tell is the sort of questions you start getting from system leaders. So I think certainly what we've found is, I think it's probably generally accepted, is that the art of asking high quality questions is an art, and it is a skill, and it's something that develops over time, and it doesn't work well if it's just decision makers asking questions in isolation. Where it seems to have improved in the Midlands is where you start getting analysts and decision makers working in far closer partnership, where the questions are asked, but also it's far more of an iterative process, and it's refined over time. I think also just people being able to see the value that outputs can add into their decision-making processes starts to sort of change the nature of the question. So I'm just thinking of those systems who've managed to create the space to undertake more in-depth work on more of the sort of long-standing challenges that their systems face. I think people are then starting to be able to ask better quality questions, and questions which potentially where the outputs add value. So I think it's something which builds over time and with practice, but doesn't really happen unless you've got the necessary infrastructure for people to be able to answer those questions effectively.
Thanks, Simon. I'm messaging the organisers, but I still don't think we've got Sue back. So
we're just Sue is I think she's on her way.
So,
I'm extremely hopeful, so I'm
good.
just looking out for
well,
her.
while we wait for her, I'm going to just pick up another question about the classic papers on from the US are the ones on learning systems. So I'm not sure I'm up to the multitasking of recovering the information from my computer, posting it into the chat, and continuing to talk to you. So if we can, we'll do that after. We'll circulate that afterwards. And one of the things that struck me visiting for a number of systems in the US is that they don't write about this stuff because it's kind of just what they do. And one is really taken. I have to say, one is taken aback by the amount of analytical expertise that you'll find just sort of embedded in the organisation. Although a lot of it, frankly, is in the BI space rather than necessarily in the intelligence generating. But I think I get the strong impression from the sort of interesting integrated systems that one has visited that the case is kind of already made. So therefore, they tend not to be writing it up very much. But I think if you look at the learning systems literature, there's quite good sort of conceptual models in there that also that in a number of those cases give some nice examples. Right, how are we doing? Oh, now this is very. A phone number has entered the chat, which is could be Sue. Is it you?
Yeah, it is. It is, Nigel. I'm so
Brilliant.
sorry.
That's okay. You've been very unlucky today. So first, you could hear us, but we couldn't hear you, and then I think vice versa. But anyway, thank you for that. So just to sort of recap, because you probably won't remember what questions I was asking you at the point we were having that technical difficulty. But if you could just perhaps talk to us about your perspective on the Decision Support Network, how it links to public health, and kind of your ambitions for where it's going to go, I think would perhaps be a good place to start, if that's okay.
Yes, of course. And again, my apologies to colleagues. So I'm Dr. Sue Ibbotson. I'm Regional Director of Public Health for NHS England in the Midlands, and have a Regional Director Office for Health Improvement and Disparities as well, and I'm one of 7 such appointments across the country, so one for each region. So the context of our involvement, and we've had, I think Gareth French may well be on the call. Gareth is our link into the Midlands Decision Support Network as our Associate Director for Knowledge and Intelligence in OHID. And the context for me, of course, for all of this is the stark issues and challenges that we've got with the health profile for people in the Midlands, and the vast and increasing, in some respects, health inequalities that we've got, inequalities of outcomes, inequalities of access, and that those inequalities are underpinned obviously by socioeconomic deprivation, but a whole raft of inequalities in the underlying risk factors for disease. And we see in all sorts of ways that poor and, in some respects, declining healthy life expectancy and all those disparities mirrored in some of the needs assessment that we do around things like urgent and emergency care. So larger proportions, perhaps up to 50% of the disease profile preventable in some shape or form. So the NHS, huge opportunity there, both in terms of secondary prevention, but also in terms of the work that it can do with partners around wider determinants. ICSs, of course, are public health organisations by definition. So our interest in the Midlands Decision Support Network is to promote and support the development across the ICSs of their population health management capability. And you've described, Nigel, the general sort of histories, lessons from history, whereby we need a cyclical approach. And of course, population health management is that as well. Needs a bunch of building blocks and needs a clear understanding of populations, design of change to tackle those health inequalities and prevent disease, and then intelligence and understanding about implementing interventions. So just the cycle that you've described, but looking at a population basis. Some of the work that Gareth in particular has done with the Midlands Decision Support Network has included looking at capabilities, and I think the work that the MDSN can do to build the capabilities across our analytic community, but also with decision makers, is really critical to this. So when we've looked at that in fairly systematic terms, we can see that whilst the ICSs have huge strengths, for example, in routine monitoring and database analysis, data visualization, and communicating to different sorts of audiences, there are also a raft of areas for development for population health management, in particularly around some of the data science skills and the options appraisal and research and evaluation skills, predictive analytics, and taking a population health approach. So that capability building, I think, Nigel, is one of the huge opportunities that we see. And I think we've got something like 1,200 analysts, something like that, across the NHS. So a significant capacity and capability that we want to build on. And of course, it's not just about defining the problem through segmentation and stratification and so on of the issues for populations, but it's also, I think, the role on evidence and what works. So in a lot of the conversations I have, for example, with the ICB chief execs, the narrative about why it's important to do something about prevention and health inequalities and to look at the population health as well as the metrics in terms of patients, then the next point that comes back to me is, well, we need to understand what we need to do, what works. So there's all of that opportunity around the evidence of what works, putting together evidence summaries and ready reckoners and so on. And some of that work, the health economics work that we can do, particularly to support some of the allocative efficiency work that people want to do. And then, of course, there's the publications that the MDSN produces on thorny issues that everybody is tackling, and there've been a number of those that have had inequalities, health inequalities at their heart, and that again we see as a big opportunity. If there's a collaborative desire from the systems to answer a particular question and then to build in the findings into the work that they will do, then that's a great opportunity. We're making links in terms of how we go forward with some of this. We're making links between the work of the MDSN and the two public health alliances that we've got, West Midlands and East Midlands. So we're connecting with the directors of public health. And a lot of that capability building needs to include not just the NHS analysts, but also local government analysts, because clearly there is a big opportunity that the ICSs have for integration and an integrated look at the health of the population in places, and at ICS level is also a big opportunity.
Thanks. Where are you up to in terms of incorporating the local authority analysts? So that's an ambition, is it, rather than something you've?
No, they are involved in the networks and some of the capability building, the communities of practice and so on that the MDSN is sponsoring. That more to do in that space, but I think we see the opportunity of bringing the NHS and local government analysts together to learn and to collaborate together as an important ongoing opportunity.
Thanks. Simon, if I bring you in at this point and maybe ask for your reflections on what you've heard and whether, in particular, looking forward, where you see some of the most significant opportunities are to build on this, and what advice might you give as part of that to other people developing these types of networks?
Yes, certainly. Thanks, Nigel, and thanks everyone for those reflections. One thing I might suggest I just turn up a little bit from my perspective is the development aspect. So I think obviously there's a lot of there's a significant narrative around the professionalisation of analytics and how do we sort of support the definition of analytical career pathways. But I think in reality, certainly across the country, I think analysts still face massive challenges in accessing development opportunities. I think there was an article a few weeks back from Andy Olowski, who's president of their professional body, AFA, just sort of highlighting essentially the challenges that these analysts actually face in terms of getting space and time to develop in the way that they need to. And I think also at times nationally, our narrative sometimes focuses a lot on the digital technology, on the data, on all the sorts of dashboards, rather than focusing on developing the skills of the people who actually undertake and draw on analytics, so both analysts and decision makers. So obviously I believe in this model. I think it provides development opportunities. As Sue was saying from the start, we've worked it off the principle that it's open to everyone in health and care. So we've had local authority and public health analysts on programmes alongside those from the NHS. Doing stuff at a regional level reduces some of the barriers to access, gives some economies of scale. Obviously, it's put together a sense of essentially a curriculum, but one that also addresses, as I was saying earlier, some of the supply issues, but also the demand side issues as well. So for the people who use analytics, I think also people doing this stuff together at regional levels, so going through development opportunities, I think builds a sense of connection, which really just reinforces all the other stuff that I was talking about around sort of sharing and collaboration between systems. I think in terms of the opportunities, I think, well, clearly, as I said earlier on, I think we are still really, even though we're sort of 2 years in the Midlands, I think we are still quite early in the journey, really. So I think once we've got all of the 11 systems with a really well-established intelligence function led by a chief analyst, with space to work on strategic analytical projects, and with, I suppose, a culture that tends towards sharing and collaboration by default, I think that's when you potentially unlock the power of the network. I think similarly, we've got the Southwest region with their arrangement in its early stages. I think if other regions in the country, start to think about similar or equivalent arrangements, I could see massive potential for open sharing of analytical code, of outputs, of skills in a way that perhaps hasn't really taken place to date. I think I'm really excited about the idea of using the network increasingly as a mechanism for collaboration. Both Pete and Sue have talked about some of the ways that we've work together in the Midlands, but I think we've got lots of enthusiasm and interest from some of the academic institutions and some of the academic collaborations in our region. So the NIHR applied research collaboratives, and I can see real potential in terms of building closer connections between academics and practitioners, and between health and care, informing some of the research agendas of some of our academic institutions, but also in terms of knowledge mobilization from the work that's being done by academic institutions. And as I sort of started to say earlier, just something about the fact that these regional networks they connect massive breadth of skills, they cover a massive geographical area, and there is significant potential to potentially use some of that to start thinking about, okay, well, if we roll out a new intervention across several systems, say for example, and we perhaps draw on some of the, say for example, in the Midlands, our evaluation network to start evaluating some of those interventions at scale, perhaps we could then use the network as a means to scale up or stop or squash what it is that we're trying. And I think it could just help us to get more into the discipline of effectively evaluating interventions and looking at how we might roll them out at scale, and then share that knowledge with other regional learning networks. So those are some of the key things I think in terms of the future. I suppose in terms of, you asked as well, Nigel, around advice for other regions who might consider taking up a similar model. I think this works because the systems own it, because it isn't top down, because it's something where people have bought in themselves as well at a wide level, and they've defined its agenda and its priorities, and they've seen for themselves where there's benefits in collaboration. So I think it makes a huge difference to have that sense of system ownership. I think it needs, without sounding too trite, it needs leaders, it needs champions. In our region, it's made a huge difference to have the likes of Sue and Pete backing it, having a ICB chief executive, Amanda Sullivan, who leads Nottingham and Nottinghamshire, having her as the chair has made a huge difference. And so I think some of those are significant. I guess the other aspect as well, which I suppose is the other side of the coin, is just ensuring that we've got some of the support of the regional leadership. So in NHS England, for example, so we're really lucky in the Midlands in that we've got the support of our regional leadership to make sure that, you know, whatever gets developed in the future builds upon what we've already got in place. But I guess there's a risk that other regions, if they didn't have that buy-in, you know, you might start to get initiatives that cut across it, and you know, you might start to get national initiatives which maybe don't build on what's there already. So I guess it's making sure that we've got a wider group that buys into it. Thanks.
I'm going to I hope won't mind. I'm just going to ask Peter Spilsbury to just talk a little bit about, I think, picking up one of the themes that we've talked about, which we've kept coming back to, which is sort of getting the questions right, and just say a little bit about what he's posted in the chat, and just elaborate a little on that, Peter, if you wouldn't mind. Is that okay?
Yes, fine, Nigel. Nice to see you. It's a good job I'm not in my pajamas, because I'm not actually working today. But anyway, that's fine. Yeah, I just posted. I hope I managed to post.
You have, yeah. No,
fine, okay.
Yeah.
Yeah, it's just a reflection really on this thing about getting the question right, because it can feel very abstract. But we've had the chance recently to just go through a process where the chief executives of a group of acute provider trusts who are working together identified some clinical areas that they felt were a priority, and they asked if we could work with some clinicians in those areas to formulate a set of questions from the clinician's perspective that they thought were important. And the way we framed the discussion with each of them was, imagine you have control over the entire resource for your service area, for the region. What would you need to know in order to make the best decisions you could about how to get the best health and care outcomes for your population? And these conversations were an education. They were absolutely fantastic from our point of view, because the clinicians had a terrific overview. As is often my experience, to be honest, they started from an interest in population health, an interest in equity, an interest in value. I think so much of the way, to be honest, the managerial class characterises clinical thinking just isn't right. But anyway, they came at it, and what really struck me was that how many of the issues that they wanted to explore were what I would call enduring problems, things that have been there for a long time. Some of them, to be honest, I heard people talking about 20 years ago, and yet we haven't tackled them systematically, because our obsession with urgency means that we never allow the time to do that. So I've had this sense of looking in on the world that these clinicians are describing and seeing a whole bunch of things that lent themselves to analytical insight, and yet where we haven't managed over a long period of time to organise ourselves such that the right analytical skills can address those. And one of the things, you know, one of my hopes for this networked approach is that one day we could get to the point where we could have a whole list of these enduring questions, and we can have distributed them across the various decision support networks across the country, and we can have a rolling programme of analysis addressing big questions rather than the stuff that we often end up addressing.
I'm going to ask Pete and Sue to perhaps elaborate on that and think about, looking forward, what are the equivalent sort of problem formulational questions that are sort of on the similar list on your agenda that you think there might be new ones, or there might be ones that we, you know, like Peter says there, that we've been thinking about for years and haven't really quite got to grips with. Who shall I come to first? Pete's looking very thoughtful. I can't tell what Sue's looking like because I can't see her, but I'll come to Pete first, and then Sue, you get a moment to think about that.
So interestingly, one of the things that we're doing with the support unit at the moment is looking at the future at some scenario planning, of really trying to draw on the experience and knowledge of our leaders to start to say, well, what are those key challenges looking forward? One of the themes that we talked about on this, what I talked about last year at the festival, was this concept of infobesity, of us all drowning and sort of flamming around really in terms of data. And one of the things that we've tried to do this year is like break our challenges down. So we've been thinking about data that we use for assurance, which often is around hospital discharge. It's often about the urgent and the immediate. What information we've got for improvement. So how do we know we're getting any better, or how do we know we're actually tackling some of the key problems that we've got? And then the third area is about planning. And I think this is where Sue and the population health management work is really key, but we don't always get, well, it doesn't get the necessary time spent on it, because we're always dealing with, as Peter says, the urgent and the now. So I think how we shift ourselves along that spectrum is a key challenge for us. And we're certainly, West Midlands Aid is trying to carve out some time to make sure that we do keep the future part of the jigsaw at the top of our list and our thinking.
So,
thanks, Nigel. So the key issue, apart from all the original kind of analysis of what the problem is to understand what difference we could really make to population health outcomes and those inequalities that we all know about if we did the things that we know work in the prevention space. And that's quite a complicated question in terms of your reference earlier to just be clear what's what the key ingredient is. Well, of course, there are lots of moving parts in that question, but being able to illuminate the difference that we could make by focusing on prevention and inequalities, and to track that as we go through, is going to be really important, because to move from a focus on individual patients and healthcare to the kind of outcomes that I'm talking about and on a population basis is a tanker turning exercise, I think, and it is going to take a huge concerted and collaborative effort at both policy and local implementation level in order to actually address the gap between healthy life expectancy and life expectancy that is creating all the demand for NHS services. So I think that those are some of the big questions for us, Nigel. What difference could we actually make, and how could we track progress? And the reason it's important to look at that, apart from the ambition to make a difference to inequalities and to prevent ill health, is because with the NHS and social care in the situation that they are in at the moment, if we don't focus on inequalities, the recovery agenda and getting to grips with all the waiting time challenges and so on is likely to increase inequalities. So we really do have to be able to demonstrate the difference that we are making if we're not actually going to create even more challenges for both people's health and the NHS.
There's one very intriguing, well, there's a number of intriguing comments, but one particular one caught my eye from Dennis Sherwood about the need to unlearn things, which I thought, and in fact, he's in good academic style put a link to his own research, which I absolutely approve of. Thanks for that, Dennis. Looks really interesting. I'm going to perhaps put that question to the panel, to Simon first, and then I'll come to Sue and then Pete. What's the one thing that we ought to that decision makers ought to unlearn? Simon, put you on the spot, and then Ali, I'm going to come to you as well. You disappeared from my screen. I hope we hadn't lost you, but yeah.
What's the one thing that I need to unlearn? this is a sort of sideways answer to the question, but I think they need to just start thinking about their decision-making practice. So I think at the moment, quite often people's decision-making gets sort of accumulated over the course of a 20 or 30-year career, and they end up in a really senior position, but they maybe don't have a tendency to reflect on how they actually make decisions or what process.
Okay.
That's my one thing.
That's good. Ali, let me come to you. I'm sorry, you had completely. I don't know whether we lost
That's
you.
okay.
But
No. I've been here. I've been here.
Good.
That's okay.
Yeah.
No, I'm going to slightly dodge the question as well, because I've been sitting here thinking, and in response to Peter's point, is just sort of thinking about the evidence that we already have. And how it's utilized. And I think we make the assumption that we do utilize evidence, and people are quite sort of, systematic in their decision making. And I think we know from diffusion of innovation research, we know from all sorts of research that that is not the case. So I think there's something about, and also how you bring people together where aspirations aren't necessarily fully shared, like you were saying at the beginning, and they don't necessarily have the same frames of reference, and they don't consider the same sorts of framing of those questions to be as important. So, the economic sort of imperative versus, addressing health inequalities, and where things might actually be pulling in different directions. But I also think it's going back to listening to patients as well. I haven't talked much about, how we generate questions from the sorts of issues being raised, at different levels, and also how we bring patients into all this work. But I do think that there is an assumption that that people are very logical, and I think sometimes actually there's so many different things that pull them in different directions to act in a certain way, including that sense of urgency that is often put in place to address difficult problems that need a longer term sort of solution.
While I've got you, let me just loop back and put the question to you about, I put to the others about future challenges, and sort of where your focus on, and whether any of those sort of questions that Peter was giving us, what's your sort of equivalent list to those?
Oh, blimey. Yeah, it's long. I think that's what I was saying about the dual running, the things that we can sort of do now. So how we can really start engaging people to collaborate and pick off some of those things. I think Sue's point around the healthy life expectancy gap, I think there's certainly in the Southwest, but obviously across the whole country, there's huge issues and huge potential to be addressing some of those, and coming up with different ways of addressing some of these things, because I think some of the solutions that have been in place are not necessarily always working. Again, linking that to evaluation so that we know, and making sure that the work that we do, and I think that's probably an area that I think there's a huge gap, is actually, one, how we connect with our academic colleagues around evaluation, but two, making sure that we weave evaluation through the different approaches and solutions that we're putting in place. So yeah, I think longer term, I think there's a huge amount of opportunity to connect, to collaborate, to do things at scale, and to network the networks. I think that's where I think we're going to, like both Simon and Peter were saying, where we could really get traction and start to make huge progress.
Thank you. So we're getting towards the end, so I'm going to ask perhaps Pete and Sue to wrap us up with one, any thoughts on unlearning, and secondly, any sort of final thoughts and that they'd like to leave us with.
I was struck, Nigel, with the theme around curiosity and whether you can unlearn being curious, because I think there's something about people becoming less curious as they think that they get to understand the problems are. So I'd say that maintaining curiosity has got to be a key challenge for all of us. No one's got the one answer, have they? So I think, looking forward, particularly from a social care perspective, I'd ask all of the participants really to be thinking about social care colleagues as being an asset and a resource to draw on, and to be curious about who they are, what they do, what the services they provide are. And in particular, how, I think the last point that was just made about making sure that, well, you'd say patients, but people actually are at the heart of our decision making, and particularly communities and people who are the most suffer the greatest challenges really in terms of inequality, that they become more central to all of our decision making that we do.
Great, thank you. Sue.
Thank you. I'm not so sure it's unlearning, but I think, and again, it picks up the point that colleagues have made, really. There is a big issue about the way in which we go round that cycle of decision making, and the way in which we use the evidence to inform the steps of the decision making, from identifying the problem all the way around the circle to evaluating whether we've made a difference to the kind of outcomes that we are seeking to change. And of course, an awful lot of the day-to-day practice is driven by imperatives and short-term challenges, which of course are very, very real. But somehow we have to find the intention, the ambition, the collaborative zest and sustained effort to make sure that we're using evidence and in a much more systematic way to inform what are really important decisions.
Thank you. Lots of very rich material there. A number of things struck me. Not sure I can summarise all of that. I think this my interest in getting better questions certainly seems to be reflected in a number of comments that people have made, and actually helping people do that and providing some tools and discipline to make sure that that's the case seems like a really important thing. The second thing that's really struck me is the importance of building the relationships both with the users of the decision support, with the analysts, with the wider community, with local government. That seems like a really important thing. And then I think this theme of actually connecting what we're doing here in terms of analysis with the sort of the fact that there are real world decisions being made, real people being affected, and actually being able to see very clearly how that link works. Everyone's really interested in developing capability and capacity. I mean, I think that just is that's taken as read. Interesting comment, a couple of interesting comments in the chat about what training and support people need to do that, whether new qualifications are required, which we haven't had time to pick up, but might be something that's worth returning to. And I think from my perspective, a really interesting and encouraging tale of quite high levels of ambition and enthusiasm for this type of model. And as I say, I think it's something new and different and exciting and important. So I wish you all well with it. I'm at this point going to hand back to Simon, who will tell us a little bit about what's happening next. And Simon, I think I've done everything I'm supposed to do. So back to you.
Well, thank you very much, Nigel, and thanks to everyone who's been part of the session today. So thank you, Sue, thank you, Ali, thank you, Pete, and to everyone who's participated in the chat box with your questions and reflections, asking us some really interesting and useful and challenging questions. So thank you for that. So we've got a great range of sessions coming up over the coming 2 weeks. There's a few of them just there, and it's got something on at least something on one thing on every day, if not a couple of things, and some great speakers, as I said, both from our region, from nationally, from practitioners, from academia. So do please check out the wider programme. I think we'll post the link in the chat box. But I think nothing much else for me to say now, other than to remind you there's a recording available that will be available if you'd like to see it. And thanks so much for joining us today. Goodbye for now.
Thank you.